So you spend 3 grueling hours in the OR, right? You execute this just flawless, beautiful 4-strand core repair on a flexor tendon.
Oh, yeah. Best feeling in the world.
Exactly. The knots are perfectly flat. The glide through the sheath is just butter smooth. You close the skin feeling like an absolute surgical
Right, and
artist.
you're feeling great about it.
But then 4 weeks later, that exact same patient sits in your clinic, tries to make a fist, and nothing. Absolutely nothing happens.
Yeah, it's brutal.
The tendon is perfectly intact, but it is just trapped in a solid block of concrete scar tissue. I mean, welcome to the paradox of flexor tendon surgery.
It really is a paradox.
It's like the one discipline where a perfect, technically brilliant operation is just entirely at the mercy of postoperative mechanics. So today we're getting into a high-yield deep dive into flexor tendon repairs, engineered specifically for residents and attendings looking for, practical operative tactics.
Yeah, and our focus today is really breaking down the mechanical realities of navigating no man's land.
Right.
We're going to deconstruct the MGH repair technique, look at how operative geography dictates your strategy, and really examine exactly why the mechanical loading in your therapy protocol will, it will ultimately make or break your entire case.
For sure. But before blade even touches skin, the mechanics have to be crystal clear in your mind. You just cannot repair a flexor tendon if you don't intuitively grasp the pulley system and how to read the injury from the outside.
Right, the anatomy is everything.
So we look at Verdun's zones to map this out, and the main event, like the crucible of hand surgery, is always zone 2.
Oh, absolutely. So zone 2 stretches from the distal palmar crease to the middle of the middle phalanx.
Right.
It's exactly where the flexor digitorum superficialis inserts. And Bunnell coined it no man's land for a very good reason.
Because it's a nightmare in there.
Exactly. I mean, you have two tendons, the superficialis and the profundus, crammed into this tight, completely unyielding fibro-osseous canal. There's just zero margin for error regarding bulk.
And that canal, it's lined by synovium and reinforced by a highly specific pulley system.
Right.
You have a mix of annular pulleys and cruciate pulleys. But clinically speaking, when you're in the OR, the A2 and A4 are your critical landmarks.
Yeah, the A2 pulley sits right over the proximal phalanx, and the A4 sits over the middle phalanx.
Okay.
They're thicker, they're longer, and honestly, they are biomechanically non-negotiable. Their solitary purpose is to hold the flexor tendon flush against the bone during the arciflexion.
And the math there is just unforgiving, right?
Completely. Losing just 25% of either the A2 or the A4 pulley puts you at a massive risk of bowstringing.
I always explain the A2 and A4 pulleys using this fishing rod analogy.
Oh, yeah, I like that one.
Right. Think of them like the guide rings on a heavy-action fishing rod. If you snap those rings, the fishing line just doesn't follow the curve of the rod anymore when you pull it tight.
Right, it pulls straight across.
Exactly. It pulls straight across the curve, it bowstrings, and when that happens in a finger, it completely destroys your mechanical advantage.
That visual is entirely accurate, because when you get bowstringing, the biomechanics of the finger just fall apart the moment arm widens significantly.
Right.
Because the tendon is sitting further away from the joint axis. The muscle belly in the forearm suddenly has to contract a massive amount just to achieve the same degree of fingertip flexion.
You're just wasting excursion.
Exactly. Your tendon excursion is completely wasted. You lose active fingertip flexion, the joint becomes stiff, and your patient loses their functional power grip.
So how do we spot these mechanical failures accurately in, busy, chaotic trauma bay or fast-paced clinic? Because pain usually limits a true active range of motion exam.
Right. Nobody wants to move it.
Yeah, a patient with a fresh laceration isn't going to just easily make a fist for you.
No, not at all. So you have to rely on visual cues and passive maneuvers. You start by just looking at the resting posture. You're looking for the loss of the normal resting finger cascade. Right.
Just like you wouldn't miss a severe ptosis in a facial consult, you cannot miss the loss of the cascade in the hand. If a flexor is cut, the injured digit will rest in a noticeably more extended position compared to the adjacent uninjured fingers.
And you also lose the tenodesis effect, right?
Exactly.
When you passively extend the patient's wrist, the tension on the intact flexor tendons naturally pulls the fingers into flexion. So if you crank that wrist back and one finger stays stubbornly straight, you are looking at a transected tendon.
Yeah, that's a dead giveaway. You also need to isolate the tendons. A lot of junior residents struggle to differentiate an FDS from an FDP laceration.
Oh, for sure.
To test the superficialis, you have to block the profundus. You do that by physically holding all the uninjured fingers in complete extension.
Because they share a muscle belly.
Right, because the profundus tendons share that common muscle belly, holding the other fingers straight completely locks out the profundus of the injured finger. So if they can still flex the PIP joint of the injured finger while you hold the other straight, the superficialis is intact. And there is a great, quick clinical pearl for the trauma bay too, the forearm squeeze.
Oh, I use that all the time.
Right. If you squeeze the proximal volar muscle bellies of a normal forearm, it will pull the fingers into a flexed posture. If you squeeze the forearm and that injured finger stays completely straight, you know your profundus is gone.
Yeah, it's such a reliable test. Let's shift gears slightly to closed avulsion injuries. In zone 1, the classic jersey finger.
Oh, the jersey finger.
A player grabs a jersey, the opponent pulls away, and the profundus is violently ripped from the distal phalanx. The timing of your surgical intervention here is entirely dictated by where the proximal tendon stump ends up retracting.
And we use the Letty classification for this, right? Which really all comes down to vascularity.
Exactly.
So type 1 is when the flexor digitorum profundus retracts all the way down into the palm. You'll usually feel a painful fullness or tenderness right at the lumbrical origin.
Right, and a type 1 requires your immediate attention. It absolutely must be repaired within 2 weeks.
Because of the blood supply.
Right. When the tendon rips and retracts that far, the vincula brevia and longa are completely torn. The blood supply is just utterly compromised. If you wait beyond 2 weeks, the tendon will shrink, become necrotic. Then you'll find it completely unrepairable.
Okay, so then type 2 is when the tendon retracts to the PIP joint.
Yeah, and in a type 2 scenario, the long vincula usually stay intact and hold the tendon up like a tether.
Okay.
So the blood supply is partially preserved. You have a little more breathing room, but the repair still needs to be performed within 6 weeks before secondary contractures set in.
And if it's a type 3, where the stump is caught right at the A4 pulley, you've essentially dodged a bullet regarding the blood supply, right? The vincula are mostly intact.
Mostly.
So I imagine the pressure is off regarding that strict surgical window.
I mean, theoretically, yes. The blood supply is intact, and the tendon hasn't retracted far enough to undergo severe shortening. You can repair those later, but in real life, you want to get in there as soon as the soft tissue envelope allows to optimize functional recovery and prevent joint stiffness.
Makes sense. So knowing the anatomy and the injury pattern gets you into the OR, but executing a repair that is actually strong enough to withstand early active motion without gapping, that's the true art form.
It really is.
Which brings us to the MGH repair technique.
Yeah, the MGH, or Massachusetts General Hospital Modified Becker Technique, is an absolute workhorse.
It's everywhere.
Right. The core principle of modern flexor tendon surgery is demanding. You need a repair that is immensely strong, yet perfectly smooth.
Because strength prevents gap formation under load.
Exactly. And a gap is just an instant nidus for adhesions, or worse, a frank rupture.
Right. And a smooth repair prevents the tendon from catching on the edges of the pulley system during excursion.
Yep.
So let's break down the actual physical construct of the MGH repair. What are we putting into this tendon?
Okay, so you are building a 4-strand core technique using 3-zel-proline in a crisscross configuration. Once that core is set, you augment the entire thing with a continuous 6-0 nylon epinon suture running around the circumference of the repair site.
Okay, wait. You are seriously using 3-0-proline for a high-tension core suture.
I am.
It's basically fishing line. It's a slippery monofilament. Aren't you terrified of not slipping or untying the minute the patient starts early active motion?
It's a common fear.
Right.
Yeah.
I mean, a lot of surgeons reach for something braided, like fiber wire or ethibond, because it grabs the tissue and holds a knot securely.
Yeah, it's the most common pushback I hear, but it fundamentally misunderstands what we need the suture to do inside the tendon.
Okay, explain that.
A monofilament like proline slides through the actual collagen substance of the tendon significantly better than a braided suture.
Oh, I see.
That superior frictionless glide is not a bug. It's a critical feature required for the most important step in the MGH technique, preloading the repair.
You're talking about the seesaw maneuver.
Yes. Before you tie your knot, you pull the proline sutures taut and carefully seesaw the strands back and forth through the tendon.
Okay.
This takes all the intrinsic hidden slack out of the construct. You dynamically compress the tendon ends together and preload the repair. If you use a braided suture, it catches and drags on the collagen.
So you think it's tight, but it's not.
Right. You might think you have a tight construct, but there's hidden slack buried inside the tendon substance.
And the minute the patient goes to therapy and fires that muscle, that hidden braided slack pulls out, and you instantly get a 1 millimeter gap at the repair site.
Exactly. Which means the healing cascade stalls, inflammatory cells flood the gap, and you get a massive adhesion block.
Wow.
So the proline gives you the slide you absolutely need to properly preload the gap. But your point about the knots is totally valid. A monofilament is slippery
Yeah, you need a lot of knots.
and requires multiple throws to be secure, and a bulky knot stack creates massive resistance to glide within that tight fibroosseous sheath.
So how do you actually manage a 6-throw Perline knot stack inside zone 2?
Here's the trick. You lay the stack of knots longitudinally along the axis of the tendon.
Oh, longitudinally.
Right. After your first secure throw, you take another small purchase with a suture needle as far away from the stack as the vertical height of the stack itself.
Okay.
Then you perform your subsequent throws, effectively pulling that entire knot sack down so it lays completely flat against the tendon rather than sticking up perpendicularly.
That's brilliant.
Yeah, it drastically reduces the gliding resistance when it passes under the pulleys.
And the actual needle passes in the MGH technique are very specific, too. It's a very deliberate geometry.
It is. You start by passing the 3-0 proline transversely through the lateral aspect of the tendon, making sure you are at least 1.5 centimeters away from the cut end to get adequate purchase.
Right.
Then you drive the needle obliquely through the tendon in a spiral fashion. You do this 3 times, bringing it out the core. You end up with parallel oblique suture lines visible on the outside of the tendon.
And then you take the other needle and run it perpendicular to that first spiral.
You cross back over, creating those crisscrosses. So you get 3 distinct crisscrosses on either side of the tendon repair.
Got it.
This geometry grabs the parallel tendon fibers beautifully and provides immense pull-out strength.
But there is a major contraindication for the MGH technique that catches people off guard.
Yes.
You cannot use it if the patient requires cast immobilization post-op.
That is a vital clinical distinction. Biomechanical studies clearly show the MGH technique, because of its complexity and the sheer amount of suture material, actually increases the baseline resistance to gliding compared to, say, a simple 2-strand Kessler.
Right.
If the patient is immobilized like a child under 10 who just won't comply with a motion protocol, or a polytrauma patient with severe combined injuries, they will develop unyielding adhesions.
It's guaranteed.
Right. The MGH repair is designed exclusively to withstand the rigors of early active motion therapy. If they can't move early, don't use it.
Okay, let's take this mechanical foundation and see how our operative tactics change zone by zone.
Sure.
Real-life geography dictates how we deploy this repair. So let's start distal with zone 1.
Okay, zone 1 is entirely distal to the superficialis insertion.
Nah.
So by definition, you're only dealing with a severed flexor digitorum profundus.
And the main goal here is getting adequate exposure without destroying that A4 pulley in the process.
Exactly. You open the finger with a Brunner zigzag incision. The physics of a Brunner are crucial here.
Yeah, you can't just use a straight line.
No, a straight longitudinal line across a joint crease will inevitably tighten and bowstring as the scar matures, causing a severe flexion contracture.
Right.
The zigzag distributes the tension vectors so the scar can stretch as the finger extends. Once you're in, if the proximal tendon has retracted slightly, you can often milk it back into the wound by flexing the patient's wrist and milking the distal forearm.
And then you pin it.
Yes, once you retrieve that proximal stump, immediately pin it transversely with a hypodermic needle to keep it from sliding back down the sheath.
Okay, but what if the distal stump is practically non-existent? Say you have a clean laceration, but there is less than 1 centimeter of tendon attached to the distal phalanx.
A primary end-to-end repair will almost certainly fail in that scenario. There simply isn't enough tissue to hold a core suture.
Right, it'll just pull right through.
Exactly. You have to advance the proximal tendon directly to the bone. You take a wronger and lightly decorticate the volar base of the distal phalanx to create a bleeding bony bed.
Okay.
Then pass your core sutures through the proximal tendon, drive Keith needles straight through the distal phalanx and out the dorsal aspect of the fingertip.
So you pull the tendon tight to the bone and tie the suture over a button resting on the fingernail.
Yes, but here's a pitfall that absolutely ruins outcomes.
Oh, the matrix.
Right. You must ensure that dorsal button sits completely over the sterile matrix of the nail bed, not the proximal germinal matrix.
Because if you compress it...
If you compress the germinal matrix with that button for 4 wits, you will cause a permanent, disabling nail deformity.
Yeah, that's a rough complication to explain. Okay, moving proximal, we enter zone 2. We are back in the claustrophobic nightmare of no man's land.
Ah, yes.
Both the superficialis and the profundus are transected.
And the spatial constraints here are just brutal. You have the profundus coursing directly through the bifurcated chiasm of the superficialis, and all of this is tightly confined within the unyielding A2 pulley.
Okay, I'm going to challenge the standard dogma here.
Let's hear it.
We are inside a tiny, confined fibroosseous tube that barely accommodates healthy tendons. Doesn't repairing both the superficialis and the profundus create way too much scar bulk?
It's a fair question.
Aren't we just begging for severe adhesions by packing all that suture material into a space that doesn't have the room for it? It seems logical to just repair the profundus and cleanly excise the superficialis slips to give the profundus room to glide?
I mean, it's a highly logical concern, and historically, that actually was the prevailing debate in hand surgery. But the longitudinal data is definitive. You absolutely must repair both tendons if technically feasible.
Walk me through the mechanism. Why risk the bulk?
There are two fundamental mechanical reasons. First, repairing both restores independent tendon glide and optimal grip strength.
Okay, sure.
But second, and significantly more importantly, the superficialis serves as the primary volar stabilizer of the PIP joint.
Ah.
If you excise the superficialis, the mechanical balance of the finger is destroyed. Over time, the intrinsic muscles overpull, and the patient is at an incredibly high risk of developing severe, debilitating PIP joint hyperextension.
A swan neck deformity.
Exactly. The finger just bends backward at the PIP. So you take the time to repair both. And crucial detail here, you must use the same strong core technique like the MGH on both tendons.
Don't skimp on the FDS.
Right. If you use a strong repair on the profundus to allow early active motion, but a weak, hasty repair on the superficialis just to save time, the superficialis will simply rupture during therapy, creating a disastrous scar block.
Makes total sense. Let's move up the arm to zones 3, 4, and 5. The palm, the carpal tunnel, and the distal forearm.
Okay, the operative game plan shifts entirely here. Space is no longer your primary enemy. Your new enemy is the sheer volume of spaghetti you have to sort through.
Right.
You often have multiple tendon lacerations mixed with severe median and ulnar neurovascular injuries. Wide, generous exposure is mandatory. You almost always need to perform a full, formal carpal tunnel release just to trace everything out.
And you rely heavily on the anatomical stacking to figure out what belongs where.
You do. In the distal forearm, the superficialis tendons to the middle and ring fingers sit distinctly volar to the superficialis tendons of the index and small fingers.
Okay.
Knowing that stacked array helps you match the proximal motor units to the correct distal stumps without crisscrossing them.
So what is the most devastating complication unique to a zone 5 injury?
Oh, on-block adherence, without a doubt. In the distal forearm, you have a massive confluence of synovial sheaths.
Right.
If you don't manage the hemostasis and therapy perfectly, all those repaired tendons can heal together in one massive cohesive scar block. Worse, they can adhere deeply to the pronator quadratus muscle on the floor of the forearm.
Wow.
Yeah. The patient loses all independent tendon glide. The entire flexor mass just moves as a single, useless, stiff unit.
Which brings us to the absolute crux of this entire discussion. You can execute a flawless, mechanically perfect MGH repair in zone 2. You can manage the pulleys perfectly, but the surgery itself is not a cure.
No, it's really not.
The cure relies entirely on the postoperative mechanical loading.
Exactly. Without rigorous, controlled hand therapy, even the best flexor tendon repairs are absolutely doomed to fail.
Let's look at the biology of tendon healing, because it is counterintuitive.
It is.
We know that if a repaired tendon is immobilized and not stressed, its tensile strength plummets by up to 50% between the first and third weeks post-op.
It is a fascinating biological reality. The extrinsic healing pathway kicks in first, flooding the area with inflammatory cells and disorganized collagen from the surrounding sheath.
And this is what causes adhesions.
Right. Meanwhile, the intrinsic healing of the tendon itself is lagging. Right when you think the tissue should be solidifying, it actually becomes incredibly soft, mushy, and vulnerable to rupture.
I explain this to patients like curing concrete.
Oh, that's a good one.
Right. When you first pour concrete, you have the steel rebar inside that's your core suture. The wet gray concrete is the healing tendon. Over those first 3 weeks, the concrete is going through a massive chemical reaction.
Right.
It might look solid on the outside, but it is actually dissolving its old damaged structure and laying down fresh, disorganized material.
Right.
If you don't manage the load correctly, it crumbles from within.
Exactly.
The magic is that controlled mechanical loading actually stressing the repair gently is the physical signal that tells the fibroblasts to align those new collagen fibers parallel to the axis of tension.
That mechanical transduction is exactly what is happening at the cellular level. Early protected motion accelerates intrinsic healing, increases tensile strength, and forces the tendon to glide, which shears away the early extrinsic adhesions to the surrounding sheath.
So the MGH protocol champions an active range of motion program. How does that mechanically differ from the older passive protocols like Kleinert or Duran?
Well, the older protocols relied heavily on rubber band traction attached to the fingernails to pull the fingers into flexion passively.
Right, you see those old splints?
Yeah, but the problem is passive flexion doesn't adequately stress the repair to signal those fibroblasts.
Ah,
The MGH protocol introduces a critical maneuver, the active hold.
okay.
The patient uses their uninjured hand to passively flex the injured fingers down into a full fist. Then, very gently, they contract their own flexor muscles to actively hold that fist position while removing the uninjured hand.
You are engaging the muscle belly and putting a very precise, controlled isometric tension directly across the repair site.
Exactly. It forces the superficialis and the profundus to fire simultaneously, creating differential gliding between the two tendons, which physically prevents them from scarring to each other.
That's smart.
By 4 weeks, they progress to active composite flexion out of the splint. By 12 weeks, the collagen is mature enough for normal, heavy activities.
But in the real world, despite our best efforts, sometimes the adhesions win.
They do.
You get a patient who comes back months later, the wound is healed, but they just cannot actively flex the finger. The tendon is stuck. When do you go back in for a tenodesis to free it up?
You have to exercise extreme surgical patience here. You should not touch that finger for a tenodesis until at least 22 weeks post-repair.
22 weeks. You're telling a patient with a stiff finger to wait over 5 months.
Yes.
Wow.
You need the inflammatory phase to completely burn out, the scar tissue to fully mature and soften, and the functional recovery from therapy to definitively plateau. If you go in earlier, the tendon is still hyperemic and intrinsically weak. You run a massive risk of literally tearing the tendon apart or rupturing your original repair site while you're using an elevator to free it from the dense scar tissue.
That makes sense.
Also, before you even offer a tenodesis, the patient's joints must be supple. If they have a stiff PIP joint from a lack of passive motion compliance, freeing the tendon won't give them any function anyway.
Good point. What if the tendon has already ruptured, or a patient presents 6 months after a misdiagnosis, and the tendon is completely retracted, shriveled, and scarred into the palm?
Well, at that point, primary repair or tenodesis is off the table. You're looking at a late reconstruction utilizing a free flexor tendon graft.
Okay.
And if the sheath is collapsed, or if you need to radically reconstruct the A2 and A4 pulleys, you cannot just lay a raw new tendon graft in there.
Because it'll just scar down again.
Exactly. It lacks a synovial environment and will instantly scar down to the bone.
Huh.
You have to execute a 2-stage reconstruction.
Okay, so stage 1 is all about preparing the environment by placing a silicone rod.
Right. You open the finger wide, excise all the scarred and useless tendon, and aggressively release any joint contractures. You secure a smooth silicone rod to the distal phalanx and run it all the way down the canal through the carpal tunnel and into the forearm.
Got it.
You leave the proximal end free in the forearm so it doesn't buckle during motion. Then, you meticulously reconstruct the A2 and A4 pulleys directly over the top of the silicone rod using strips of tendon graft or retinaculum.
And the body obviously recognizes the silicone rod as a foreign object, but we use that biological reaction to our advantage.
Yes. The body attempts to wall off the silicone by forming a smooth, highly organized synovial-like membrane completely around it.
Which is exactly what we want.
It creates a brand new, pristine biological pseudosheath that is perfectly lubricated and ready to accept a real tendon.
How long does it take for that pseudosheath to mature?
3 months. That's the timeline for stage 2. You bring the patient back, make a small incision distally at the fingertip and proximally in the forearm. You attach your real tendon graft to the proximal end of the silicone rod.
Oh, and just pull it through.
Exactly. As you pull the rod out from the distal end, it acts as a perfect shuttle, threading the new graft precisely through your reconstructed pulleys and through that frictionless biological pseudosheath.
Amazing. Where are we sourcing this tendon graft, though? Because we need a lot of length.
It depends entirely on the required span. The palmaris longus is the absolute workhorse. It's usually in the same operative field, and it gives you about 16 centimeters of high-quality graft.
Okay.
That's typically enough to bridge a gap from the mid-palm to the fingertip. You harvest it through a couple of small transverse incisions using a brand tendon stripper.
But the palmaris is congenitally absent in, what, up to 25% of patients?
Yeah.
Or what if the proximal muscle unit has retracted all the way to the mid-forearm and you need a graft to go all the way from the distal tip back to the proximal forearm?
Then you transition to the leg and take the plantaris tendon. It's just medial to the Achilles tendon and gives you a massive 35 centimeters of length, which is enough to span almost any upper extremity defect.
Wow, that's huge. When you are setting the tension on that final graft in stage 2, how tight do you actually weave it into the proximal motor unit?
You usually weave it into an active profundus or superficialis belly in the forearm using a pulver-taft weave.
Right.
And you must set the tension so the injured finger sits about 1 centimeter tighter or more flexed than the normal resting cascade. The graft and the muscle will inevitably stretch out a bit during rehab.
And if you set it too loose...
If you set it too loose, you run into the quadriga effect.
yeah.
Because the profundus tendons of the middle ring and small fingers share a common muscle belly. If one tendon is excessively loose, the muscle contraction reaches its maximum excursion before the loose tendon ever gets tight.
Oh, man.
Yeah, the patient ends up with a profoundly weakened grip in all the uninjured fingers because the shared muscle belly is effectively bottoming out early.
All right, let's pull the mechanics of this together. What are the absolute core, non-negotiable takeaways for a surgeon stepping into one of these cases?
First, respect the mechanical architecture. Preserve or reconstruct the A2 and A4 pulleys at all costs, or your patient will suffer debilitating bowstringing and loss of excursion.
Absolutely.
Second, when you're navigating Zone 2, fight the urge to simplify. Repair both tendons using a strong 4-strand core technique like the MGH. Utilize a monofilament to allow for adequate seesawing and preloading and lay your knot stack completely flat to reduce friction.
Right.
And finally, recognize that your surgery is just the biological setup. Early controlled mechanical loading, specifically the active hold protocol, is biologically mandatory to align fibroblasts, prevent adhesions, and restore functional glide.
I mean, I want to leave you with a provocative thought, thinking about where this field is heading.
Okay.
We spend so much time, energy, and operative stress fighting the cellular biology of weeks 1 through 3. That brutal period where the healing tendon is mushy, vulnerable, and throwing off adhesions.
Yeah, the danger zone.
What if, in the near future, we could bioengineer an injectable, highly viscous synovial fluid substitute? Something you physically bathe the tendon in before you close the skin that completely blocks fibroblast adherence to the sheath during that critical 3-week window while still allowing intrinsic healing.
Yeah.
I mean, it would essentially eliminate the friction coefficient and make secondary tenodesis a relic of the past.
A biological barrier like that would completely rewrite the mechanical rules of hand surgery.
It really would. But, until that fluid hits the market, we rely on the mechanics. We rebuild the engine, we meticulously preload the tension, and we trust the biology of early motion to do the rest.